Hi, I'm Dr. Reva Basho from the Ellison Medical Institute in Los Angeles. I'm here at the San Antonio Breast Cancer Symposium, excited to share my poster. We have a poster today on predicting pathologic response in early HER2-positive breast cancer using a foundation model in digital pathology. So let me walk you through our work. So we know that in neoadjuvant HER2-positive breast cancer-treated patients, those patients who achieve absence of disease at the time of surgery or pathologic complete response have very good long-term outcomes. We treat patients generally the same regardless of what their disease features are aside from HER2 positivity. So all HER2 positive breast cancer patients in the early stage setting that receive neoadjuvant therapy tend to receive today the standard regimens that are available to us. But we know that between patients who are hormone receptor positive and hormone receptor negative, there are drastically different rates of pathologic complete response. So within these two cohorts, can we get better at predicting who is going to respond to our treatments today? That was really the goal of our work with this poster. So we used a digital pathology foundation model, CAN-VOI, developed by Imaging, to apply to a data set of diagnostic biopsies, H&E images from diagnostic biopsies for patients with HER2-positive early breast cancer planned for neoadjuvant therapy that involved taxane-based treatment plus anti-HER2 therapy, so really standard treatment in our paradigm today. We applied that foundation model to those diagnostic images to predict pathologic complete response. So our data set came from 3 cohorts that were pooled together. One was an institutional cohort, and 2 were publicly available cohorts, the Yale and IMPRESS data sets. We took the H&E baseline biopsies, divided them into 380 by 380 pixel tiles, and then applied the CAN-VOI foundation model. We then did 4x4 cross-validation using random partitions and then applied logistic regression and other machine learning classifiers to predict pathologic complete response. We also did some data balancing to try to improve our prediction, and then we applied a multivariable model incorporating clinical data as well. So here's our workflow that I just walked you through, dividing our histologic images into tiles and then tile vectors that were pooled together into slide vectors and then applied to machine learning models. Here are our patient characteristics across each of the 3 cohorts that were included in our study. So you can see, as would expected, the majority of the patients had ductal disease. Majority of patients had high-grade disease where the data was available. Majority of patients had HER2 3+ disease, with a number of patients having HER2 2+ disease that was FISH positive. We were about evenly split between hormone receptor positive and negative disease. We generally had T2 and node positive tumors. You can see the rates of PCR, or pathologic complete response, across the 3 cohorts were generally similar. Here we divided our patients into hormone receptor positive and negative cohorts to take a closer look. And you can see that the rates of PCR were generally higher in patients who were HER2 3+ with hormone receptor positive disease, and generally grade 2, grade 3 had similar rates of PCR. Looking at patients with hormone receptor negative disease, again, patients who had HER2 3+ disease had higher rates of PCR. And here you can see that numerically high-grade disease tended to have a higher rate of PCR, but this was not statistically significant. So coming now to our machine learning models, you can see each of these box plots is a different machine learning model that was applied. The logistic regression is displayed first. So looking at hormone receptor positive subset, the PCR prediction across models was fairly consistent and around an AUC of 0.7. In the hormone receptor negative subset, again, fairly consistent across machine learning models with an AUC of about 0.7. When we applied some data trimming for data balancing with hopes of improving our prediction, we saw that there was really not much change. So our AUC remained around 0.7 for hormone receptor positive disease And again, maybe even slightly a little bit lower, but in the 0.6 to 0.7 range in hormone receptor negative disease. We then applied clinical variables, a multivariable model that include clinical variables as well as our model, and then combined the two to see if we could amplify our model with the addition of clinical variables. So you can see the AUC predictor. The clinical variables that were used here were HER2 2+ versus 3+, and grade, high grade versus grade 1 to 2 disease. And you can see the clinical predictors had a lower AUC than the model, although not statistically significant. But when we combined the two, the clinical predictors as well as the model, particularly in hormone receptor positive disease, we did see a better AUC. These values are not statistically significant, but our overall data set is small. It's nice to see that trend. So in conclusion, we found that a digital pathology-based machine learning model could help us better select patients for neoadjuvant therapy, planned for neoadjuvant therapy with HER2 positive early breast cancer. And our hope is that we really continue our work, get access to larger data sets to continue to build this work and hopefully have better predictors, because the hope is that such models might help us better select patients for various clinical trials and therapies in the future. Thank you so much.